All right, this is just a synopsis of what we talked about in class. So, we talked about cardiac medicines. Please be aware that these are not all of the cardiac medicines. There's other classifications that we need to go over. I just didn't think that we could go over all of them. We still need to go over statins and cholesterol lowering medicines other than statins, and anticoagulants. So not all the medicines. We still have more. Remember that before implementation of medicine, lifestyle modifications are always going to be your first line. So we have nutrition, exercise, smoking cessation, just as a couple examples. So what this PowerPoint is going to cover are the classifications that are listed on this slide. The first classification we're going to talk about are diuretics. Loop diuretics, they commonly end in IDE. Not all loop diuretics do, but many do. So furosemide, butanide, and torsemide are a few. Your expected action is it works in the ascending limb of loop of Henle, which is why it's called a loop diuretic. It's going to promote the excretion of pretty much all your electrolytes, and you have widespread diuresis even if you have severe kidney damage. So loop diuretics are going to be used for somebody that does have severe renal failure because the other diuretics can't be used. The therapeutic use, cardiogenic pulmonary edema, hypertension, and then any type of edema that stems from liver, cardiac, or kidney issues. It can be administered intravenously, it can be administered by mouth or intramuscularly. Complications, hypokalemia, dehydration, hypotension. Those are your major ones. Then you can have hyponatremia, hypochloremia, and hyperglycemia. Those are more mild. Your education, you're going to tell the patient to report a significant decrease in their urine output because if they're not able to urinate what we're trying to diurese, then they could have a buildup of electrolytes. You want to educate on the importance of daily weights, especially if the person is on the diuretic for heart failure. Give them some symptoms to expect of postural hypotension or orthostatic hypotension. They're the same thing. So are they dizzy with position changes? If they are, you want to teach them the importance of slowly changing positions. Educate on high potassium foods and manifestations of hypokalemia. Remember, your manifestations are a sick waltz. So things that you want to definitely tell this patient, they can expect lethargy, irritability, shallow breathing. They might expect palpitations. Those are all symptoms of low potassium. Tell the patient to take the medicine earlier in the day so they don't have nighttime nocturia, which is urinating at night. Some considerations, you want to assess for dehydration, of course, because it's diuretic. You're going to monitor your electrolytes, mostly your potassium. You want to monitor your other electrolytes, but potassium is very important with these kinds of medicines. Monitor their urine output and their kidney function. If it's less than 30 mLs an hour, you need to stop administering and alert the provider. So a patient who has diminished urine output and you're giving them a diuretic to urinate, there's something going on. You want to look at their BUN and creatinine for kidney function because if their kidney function is impaired, they might not need to be on the loop diuretic. But remember, it is the only diuretic that they do give in kidney failure. When you give the medicine IV push, remember that if you give it too rapidly, it can cause ototoxicity. I can't talk. So for furosemide, it's 20 milligrams per minute. So if you have like 100 milligrams to give IV, it's going to take you 5 minutes. And then again, monitor for symptoms of hypokalemia, which I talked about in the other slide. Your interactions, if you're on, or if your patient is on digoxin, then you want to monitor for toxicity, because hypokalemia potentiates digoxin toxicity. Symptoms of digoxin toxicity: visual halos, blurred vision, double vision, anorexia, nausea, vomiting. Those are things, symptoms of digoxin toxicity, and things to be alert for when your patient is on a loop diuretic. Remember that any medicine that can lower your blood pressure is going to potentiate hypotension. That's just general. Hyponatremia from the diuretic can potentiate the lithium toxicity, and NSAIDs can decrease your diuretic effect due to decreased blood flow to the kidneys. Your thiazide diuretics, so those are going to be medicines that end in thiazide for the most part. There are a couple of other thiazide diuretics that do not end in thiazide, but for the most part, if it's thiazide, it's going to be a thiazide. Hydrochlorothiazide, chlorothiazide, methylclothiazide. These work in the distal convoluted tubule, and they block sodium, chloride, and water from reabsorbing and promote potassium excretion, and they promote diuresis when you do not have an impairment in the renal function. These are going to be your first-line hypertension medicines. Remember when I discussed fluid and electrolytes, I talked about how if somebody has fluid volume excess, if it's mild to moderate, they're going to be put on a thiazide diuretic, and if it's severe, it's going to be a loop diuretic. Same concept. First-line hypertension here with the thiazides. Mild to moderate edema related to heart failure, liver, and kidney disease. This has a paradoxical effect of decreasing the urine in diabetes insipidus, and it promotes reabsorption of calcium, so when a person is hypocalcemic, you can give it. And it also will help prevent osteoporosis if they have low calcium. The administration is PO. With thiazides, the only one given IV is the chlorthalidone. Your complications are going to be low potassium, dehydration, those are your big ones. And you're going to have hyponatremia, hypochloremia, and hyperglycemia as well. Again, your patient education, it's pretty much the same as a loop diuretic. Educate on foods high in potassium. Educate on symptoms of hypokalemia. Teach about efforts to reduce postural hypotension. Tell a patient what postural hypotension is. Take early so they don't have nighttime nocturia. You want to do daily weights, and you want to be aware if they have decreased urine output. For your nursing considerations, you're going to assess and monitor for signs and symptoms of dehydration, monitor that cardiac status, especially if they have hypokalemia. Monitor for an increase in blood glucose, since the thiazide can mask hyperglycemia. Monitor your electrolyte levels, especially your potassium, and monitor urine and notify provider if it's less than 30 mLs per hour. So what's the difference between the two? Well, mechanism of action, so your loops are going to work in the loop of Henle. Your loops are going to be more potent. They're going to be given with severe kidney damage, and they can be ototoxic. Your thiazides are going to work in your distal convoluted tubule. They are the first line for hypertension when it comes to a drug, and they are not given in patients with kidney damage. They're not ototoxic, and you could lose more magnesium with them. Potassium-sparing diuretics. So these block aldosterone action, causing excretion of water and sodium and retention of potassium. So the therapeutic use is when you're on a loop and thiazide diuretic, they might combine those with a potassium-sparing diuretic to help with the potassium loss. Heart failure, and then it can also, because it blocks our aldosterone effect, be given with primary hyperaldosteronism. The administration of the potassium-sparing diuretics is going to be oral. Our complications: hyperkalemia and metabolic acidosis. The patient could also be drowsy and have endocrine issues. Big patient education. You want to educate patient to avoid salt substitutes. Going to teach them about signs and symptoms of metabolic acidosis. Remember, with metabolic acidosis, the patient that is exhibiting these signs and symptoms is going to have vasodilation, so they're going to feel flushed. Their blood pressure could be low. They are going to have diarrhea, which is a cause. And they're going to exhibit nausea, vomiting, which is a symptom, but if they have prolonged vomiting, that is a cause of alkalosis. Okay, so don't get those confused. You want to teach your male patients that they could possibly get a deepened voice, and your female patients could have possible menstrual irregularities, and if something like that were to happen, then they need to alert their provider. And you want to give them drowsy drug instructions, such as do not operate any heavy machinery until you know the effects of this medicine. Your considerations: monitor for hyperkalemia. And if hyperkalemia occurs, you're going to treat it by A, discontinuing your medicine and administering insulin or potassium-wasting diuretic. The administration of ACE inhibitors, ARBs, and potassium-sparing diuretics, all those together, can cause potassium elevation and should be monitored vigilantly because ACEs and ARBs also can cause hyperkalemia. Don't give potassium supplements, and monitor the EKG and blood pressure as needed. So your ACE inhibitors, angiotensin converting enzyme inhibitor, angiotensin 1. So this keeps your angiotensin 1 from converting to angiotensin 2. The majority of your ACEs are going to end in pril. Your expected action, you're going to block the conversion of angiotensin 1 to angiotensin 2. This will block the aldosterone from being released, so your body does not experience the effects of aldosterone, which causes the body to experience vasodilation, potassium retention, and excretion of sodium and water. Some therapeutic uses: hypertension, heart failure, MI, and diabetic and non-diabetic nephropathy. So if you have a patient who is on an ACE inhibitor and they don't have hypertension, but they do have diabetes, well, that's why they're getting it, to help protect their kidneys, because it does have a kidney protection effect. So, complications: cough, hyperkalemia, angioedema. Those are your big ones. Cough is your most common. Angioedema is your most significant, most adverse. Please do not get those confused. And then hyperkalemia. You also can have orthostatic hypotension, and if the patient's on captopril, they could possibly have neutropenia. It's very rare. Your big things with this patient education: you're going to educate the client that a dry cough can occur, and when a dry cough occurs, they need to alert the provider stat immediately because they need to DC the medicine. If a patient develops angioedema, remember it is life-threatening. They need to be aware of possibility of swelling of their face, throat, and lips, and go to the nearest emergency room. If they do have angioedema, the treatment is going to be giving them subQ epinephrine. Also, these people need to avoid the use of salt substitutes because the majority of your salt substitutes have potassium in them. If the patient gets pregnant, they need to tell the provider because this is a category C or D, I can't quite remember, but it causes issues with the second and third trimester. When you start therapy, you need to give them some education about the fact that this medicine will make them sleepy. And then they also can have initial hypotension, so you need to monitor them for about 2 hours prior to the first dose to make sure that they do not have severe hypotension. Your considerations in conjunction with other blood pressure lowering medicines, they can have significant hypotension. Again, with anything that's going to lower the blood pressure, there you go. I already said that angioedema will require subcutaneous epinephrine, and then supplements, potassium supplements, and potassium-sparing diuretics can increase the risk of hyperkalemia. ARBs, angiotensin II receptor blocker. All your ARBs are going to end in artin. So losartan, valsartan, olmesartan, those are all examples of ARBs. ARBs will block the action of angiotensin II, which is a vasoconstrictor. And this does not release the aldosterone in the body, which retains the sodium in the water. So your body will vasoconstrict if it's got sodium and water in it. And So I apologize. So when your body doesn't release aldosterone, then you're going to excrete the sodium and water, and your body's not going to retain it. So then your body's going to vasodilate because it's released the sodium and water. So the therapeutic use is high blood pressure, heart failure, diabetic nephropathy. Certain ARBs are used for heart failure, valsartan and candesartan. And then for nephropathy, we have losartan and irbesartan. They also can protect against myocardial infarction, stroke, and cardiac death in anybody who's unable to tolerate an ACE. Myocardial infarction, valsartan, and diabetic retinopathy would be losartan. Administration of ARBs are PO. Complications, angioedema. How about that? Fetal injury, hypotension, dizziness, and lightheadedness. So the big one is angioedema. Now, it's not as common as it is with an ACE inhibitor, but it can happen. And remember, it's life-threatening. And patients need to be aware of possibility of swelling to face, throat, lips, and arrive to the nearest ER. Sub-Q epinephrine will help that. Be cautious with position changes, and remember that women who are childbearing should not be on an Artin, or they need to alert the provider as soon as they become pregnant. Some considerations: life-threatening angioedema needs to be treated. It needs to be treated with sub-Q epinephrine. You're going to monitor blood pressure, and it can be taken with or without food. You don't want to administer ARBs or ACEs to anybody with a single kidney, or anybody who has bilateral renal artery stenosis. So what's the difference between an ACE and an ARB? Well, it's all in where it happens. So with ACEs, they block the formation of angiotensin I, and with ARBs, they block the actions of angiotensin II. Your aldosterone agonists, these are going to mostly they're going to end in ONE or 1, so spironolactone, eplerenone. They block the aldosterone, which reduces volume, promoting excretion of sodium and water, and it retains potassium, so they're going to spare potassium. Therapeutic use, high blood pressure, heart failure. So your big complications, of course, are going to be hyperkalemia. You can also get dizziness and fatigue with them, some low sodium, flu-like manifestations, and gynecomastia, which is bigger breasts on men, basically. Some education for our patient. You want to educate them to monitor for symptoms of hyperkalemia. Remember, hyperkalemia, the acronym is murder. So we have some muscle weakness, deep tendon reflexes are elevated. Remember, you're going to have hyperkalemia. The acronym is murder. Stands for like muscle weakness, some urine abnormalities, not going to produce as much urine, respiratory depression, dysrhythmias, your heart rate's going to be weak, low blood pressure. You want to educate them to avoid potassium-rich foods and avoid salt and avoid grapefruit juice. Grapefruit juice interferes with a lot of things. Your considerations: medicines such as verapamil, which is a calcium channel blocker, ACE inhibitors, ARBs, potassium-sparing diuretics, and NSAIDs can all increase your risk of hyperkalemia, and you do not want to administer with potassium supplements. Some calcium channel blockers usually are going to end in pine, like amlodipine, nifedipine, but then you're going to have some that are cardizem, diltiazem. So you have two different types. Your type 1s are going to, which is your cardizem, your diltiazem, your verapamil, they're more about conduction. And then your pines are going to be more about blocking the calcium channels in your blood vessels of the heart, which leads to vasodilation. Now, both of amlodipine, nifedipine, cardizem, they both do the latter. They block the calcium channels. But only the cardizem, the diltiazem, the verapamil, those are going to be, they're going to work on your conduction system. So they're more for like cardiac dysrhythmias. Some therapeutic uses: high blood pressure, chest pain, and then the dysrhythmias, which is your cardizem, your verapamil, your diltiazem. Complications for both: you're going to have acute toxicity, orthostatic hypotension, and peripheral edema. Then for pines, reflex tachycardia, and for cardizem, verapamil, diltiazem, you'll have dysrhythmias and cardiac function suppression, as well as constipation. The administration of these meds: we have PO, intravenous push, and IV drip. You want to educate your patient to monitor weight, monitor edema, and blood pressure. The edema can be in their lower extremities, and if that were to occur, they need to let their provider know. They want to be cautious with sudden movements. Anybody that's on a medicine that can lower the blood pressure needs to be cautious. For patients on verapamil, they, of course, have the complication of constipation, so they need to increase their fiber intake. Advise the patient to refrain from grapefruit juice. Grapefruit juice interferes with the metabolism of the calcium channel blocker. If they should have fatigue or slow heart rate, which would be a sign of toxicity, they need to let the provider know. And if they're on digoxin toxicity can occur, so have digoxin levels checked at initiation of calcium channel blocker therapy. Oh, and this is less than 60 heart rate, less than 100 systolic blood pressure. Considerations: signs of toxicity include hypotension, AV block, bradycardia, ventricular tachydysarrhythmias. You are going to be prepared to cardiovert and pace, but that's more critical care, and we aren't really going to talk about that. Monitor for increased heart rate. You can use a beta blocker to help counteract the effect of an increased heart rate. Cimetidine, ranitidine, and grapefruit juice can lead to toxicity. Verapamil and digoxin will potentiate each other, so digoxin can cause AV block with verapamil, and verapamil can cause digoxin toxicity. And then you're going to give slow IV push over 2 to 3 minutes. Centrally acting alpha agonist. Oh, I forgot to do a heart on this too. So clonidine is an example. The expected action is it's going to work upon the CNS system, which decreases the sympathetic outflow and results in decreased stimulation of your adrenergic receptors, which causes vasodilation, so your blood pressure decreases, and bradycardia and decreased cardiac output result from decreased outflow to the myocardium. The therapeutic use is high blood pressure, severe cancer pain. Off-label, it's used for Tourette's, ADHD, migraines, menopausal flushing, and withdrawal management of opioids, tobacco, and alcohol. Some of your big complications are drowsiness and rebound hypertension. The rebound hypertension is only if the medicine is stopped suddenly. Patient education: drowsy drug information given and advise will subside longer medicine is used. So you generally will build up a tolerance, basically, to being drowsy. You want to advise the client to discontinue gradually so they don't have the rebound to hypertension. And then considerations, other CNS depressants can potentiate CNS effects. So beta blockers, they end in LOL. We have cardioselective, non-selective, and then alpha and beta blockers. So your cardioselective, your metoprolol, esmolol, atenolol. Non-selective are propranolol and nadolol. And then alpha and beta are carvedilol and labetalol. The therapeutic use of a beta blocker is it decreases our heart rate, decreases contractility, and decreases cardiac output, as well as decreasing the rate of conduction through the AV node. The alpha blockade will add vasodilation. That's with your carvedilol and your labetalol. And then these beta blockers also keep renin from being released, which decreases our angiotensin II. So because renin is not being released, water and sodium are being excreted and vasodilation is being promoted. Beta blockers can be given by mouth or IV. Your big complications, bradycardia, decreased cardiac output, and orthostatic hypotension. You can also have masking of hypoglycemia. You could have an AV block because you get like a buildup and become toxic, and it causes your heart rate to basically bypass the pacemaker of the heart. And you can have bronchoconstriction and asthma. Patient education, you're going to teach the patient to take the pulse and the blood pressure. So if their heart rate is less than 60 or their blood pressure is less than 100, they need to notify their doctor. And then you want to educate diabetics on the fact that this will mask tachycardia, which can be an early sign of hypoglycemia, so they need to be more vigilant in monitoring their blood pressure. Nursing considerations, you want to take the pulse and blood pressure immediately before administration. If the heart rate's less than 60 or the blood pressure is less than 100, you need to notify the primary care provider. Use caution in patients with heart failure and monitor for signs and symptoms of worsening heart failure. Monitor patients with diabetes for hypoglycemia, and concurrent antihypertensive medicine can intensify the hypotensive effect. I don't know if I can say that enough. Don't give to patients who have slow heart rates. Cardiac glycoside, your big example is digoxin. The expected action, digoxin increases the force of the contraction and helps to decrease the heart rate. The force of the contraction helps to improve the effectiveness of the heart, which helps to improve cardiac output and helps to improve stroke volume, and decreases heart rate. That gives ventricles more time to fill with blood and improve the cardiac output and stroke volume. Therapeutic use, heart failure, dysrhythmias. We administered this medicine by mouth, IM or IV. I've never given it IM. The complications, well, they're all red. Dysrhythmias, cardiotoxicity, and GI effects and CNS effects. The GI and CNS effects are mostly with digitoxicity. So some education. You want to educate them on low potassium. What are your symptoms of low potassium? You need to know those. You want to instruct them to eat high potassium foods. You want to tell them to monitor their heart rate and to report any irregularity, because this medicine is going to help control their heart rate. And if the heart rate is irregular, then it's not doing its job, and they might need to be upped on their digoxin. You're going to tell them to monitor GI and CNS effects. So nausea, vomiting, abdominal pain, fatigue, yellow halos, blurred vision. These are all symptoms of digitoxicity, and the patient needs to be aware of that. You do not want to double dose this medicine. Remember that hypokalemia potentiates digitoxicity and potentiates dysrhythmias. Loop and thiazide diuretics, so if the patient's on dig and they're on a loop diuretic or a thiazide diuretic, the hypokalemia risk increases. Antacids will decrease the absorption of digoxin. Signs and symptoms of toxicity include fatigue, nausea, vomiting, anorexia, abdominal pain, yellow halos, double or blurred vision. Get the apical pulse before you give it, and then make sure you give it within 5 minutes when you give it IV. No quicker than 5 minutes. When you're managing digoxin toxicity, you want to, A, stop the digoxin. How about that? And any potassium-sparing medication. The antidote for digoxin is going to be called digoxin immune fab. This antidote binds to digoxin and helps to prevent the absorption of digoxin. All right, vasodilators. The one that we are going to use is nitroglycerin because nitroglycerin is very important to know. This can be administered in a variety of ways. The action is chronic stable exertional angina. This will cause a vasodilation, which decreases the venous return. That basically is helping the preload, and will decrease the oxygen demand of the heart. The therapeutic uses, we have acute angina, stable angina, variant angina, and then also you can use some vasodilators are used in hypertension, and then heart failure from a heart attack. So all of the patient education is read except for that first sentence. I probably should make that red too. Just know all of it, right? So if a patient takes nitroglycerin, they could develop a headache. So you need to let the patient know about the side effects: flushing, throbbing headache, low blood pressure, tachycardia. Avoid sudden position changes. If the patient has a headache, give them some kind of mild analgesic like Tylenol. Medicines such as Viagra, which is a phosphodiesterase inhibitor, should not be taken in conjunction with nitroglycerin because of the complication of severe life-threatening hypotension. You're going to use sublingual nitro tablets or spray at the first indication of pain or when there's any anticipation of exercise. So if the patient is anticipating mowing the grass or anticipating having sexual intercourse, they need to take their nitro. Make sure that the patient knows to carry their nitro at all times and to keep it in an original dark container and at room temperature. Not too hot, not too cold. Tablets are good for 6 months. They need to place the tablet under their tongue and let dissolve. They can take a sip of water if that will help moisten their mouth, but not swallow the tablet. It needs to go through the buccal cavity. Do not inhale when they spray nitroglycerin into the oral mucosa. You want the patient to say that they need to make note of how long it takes to relieve the discomfort, because if they have to take more than 3, they need to let EMS know about their chest pain and know if it's helped or not. You want to tell them to be seated so they don't get hypotensive and so they don't have a syncopal episode. So a passing out episode is syncopal. Some considerations: phosphodiesterase inhibitors, Viagra. Sildenafil potentiates hypotension. Again, refer to education for anything that the nurse should know as well. If you are giving nitroglycerin, so you're in the hospital and you're giving nitroglycerin for chest pain, you need to make note of their pain, what type of pain it is, their blood pressure, their heart rate, and the time that you're giving the medicine, because you need to make note if it's improving the chest pain. Don't want to touch the patch or the ointment with your hands because guess what? It can cause the same effects to you. If you're giving it IV, your tubing needs to be vented, and you want to make sure the patient is on a heart monitor continuously while you're giving it. All right, so that's the end of the slideshow. It's 35 minutes. I hope you learned something in class today, and I will work on doing other slideshows for you throughout this week and next weekend. All right, thanks. See you on the flip side. How do I stop it?